Good evening. My name is Michael Robinson, and I will be discussing a topic that's near and dear to my heart, which is hip and knee replacements, and specifically some advances that we've seen in the last several years in regards to patients and what kind of relief that they can get for their arthritis with these types of surgeries. Again, my name is Michael Robinson. There's a little bit about my background. Specifically, my training is in joint replacements, and that was done up in New York City at a hospital for special surgery. And then after completing that fellowship, I came to Jacksonville. This is during my time with the Navy, and spent 10 years at the Naval Hospital setting up the joint replacement service at the Naval Hospital here in Jacksonville. While there, I was the first Navy surgeon to perform an outpatient joint replacement, and then retired from the Navy after 21 years and joined Southeast Orthopedics in October of 2020. Currently practicing out of the Riverside office as well as the Northside office. A little bit about myself. My experience is specialized in the knee and hip arthritis. And specifically in regards to knee replacements and hip replacements, but also do a fair amount of non-surgical treatments, and we'll talk a little bit about what that is for arthritis. But my subspecialty training is in evaluation and treatment of patients who had previous knee or hip replacements, specifically those who may have some persistent pain, new pain, instability or malalignment of their joints, or overall failures. And so evaluation of those is a large portion of my practice currently. So background in regards to what we'll be talking about tonight is arthritis. And I find that the word arthritis can be used in many different ways, but just to have a common language tonight is in regards to what osteoarthritis, which is the most common arthritis that we see, and it specifically is about 97% of all arthritis that present to orthopedic surgeons. It's the wear and tear arthritis, I guess it's commonly called. But what that is that articular cartilage, that smooth cartilage that you see at the end of a bone, as that wears down over time, it doesn't wear out in a nice smooth surface. It actually wears out more in a pothole type of pattern. And the bone underneath that cartilage starts to see forces applied to it that increase the pain that people see. And so that bone reacts, and it reacts with pain, it reacts with stiffness, it reacts with swelling, and the tissues around there go through that. So the arthritis is more than just an inflammatory process, but actually a physical process that happens inside the joint. And that's why people will have pain, some loss of the motion in the knee or the hip, but also some deformities that we can see that start to change as that cartilage wears down. The current treatments for arthritis are both surgical and non-surgical. The most common treatments that we talk about with the non-surgical treatment, what we call the main five, which is medications, anti-inflammatory or arthritis type of medications. These can be very effective in regards to helping with the early onsets of arthritis, but it is also a foundation in treatment of osteoarthritis as it progresses. Injections, specifically steroid injections and viscosupplementation injections, are the two most common injections that we perform. And those have different indications, but are both used for symptomatic arthritis and have both advantages and disadvantages to both of those. Exercise is a treatment for arthritis. We talk about arthritis not in regards to just letting it rest, but actually we find that activity is a good way to help make arthritis less painful. It improves overall conditioning and function. We're not talking about excessive exercise, but we found that rest, it always does, rest may not give people the relief that they were looking for, but moderate exercise and specifically working sometimes with a physical therapist or working with a trainer may help you get to the point in regards to improving your function and specifically the pain. It can also improve motion. One of the complaints that people have is a loss of motion, whether it's with the hip or whether it's with the knee, but these type of modalities can help in regards to that. None of these treatments have been shown to increase the arthritis or increase the cartilage, and that's the biggest advantage of some of these, is that we're not there to cause cartilage to grow back, but allow you to be functional in regards to that. Weight loss also can be very and help improve pain. Specifically what it is a basic physics. The more strain that you put on an arthritic joint, the more pain that you will see. And we'll see that patients who lose even 10 pounds will see a 40-pound difference in stress or strain across the knee joint just by that small amount of weight loss. And that can be very beneficial for people with symptomatic osteoarthritis. Bracing, some deformities can be improved with bracing. This can allow people to be functional, and allow patients to be able to do activities, specifically if you're someone who does a lot of standing or walking. Surgery is a non-surgical treatment, or is the surgical option of choice. Specifically for that is a joint replacement, and what that is, we'll go over a little bit of what that means. We help with, one of the ways we determine the arthritis level is specifically is four main ways. One is through a physical exam. Visiting with your orthopedic surgeon or your primary care can help give a lot of ideas in regards to what type of deformities we're dealing with or the severity of the arthritis. Specifically is the x-ray examination. A lot of x-rays for the knee are done in a weight bearing where you're standing, and we can see that joint space where it is between the bones. As that decreases, we see increasing in the severity. And as you can see in the picture onto the right, as that joint space narrows, that is an increase in regards to the severity of the arthritis. Medical history. Medical conditions can play a role in regards to your arthritis as well. There's different conditions or medications that may improve or actually make your arthritis worse. And so those are important things to have to give to your physician when you have an evaluation. Previous treatments, whether that is some of the treatments that we talked about before, but those can be give a guidance in regards to what's the next step in regards to the treatment of osteoarthritis. So total joint replacements, this is relatively new. It's in regards to, we started it about 40 years ago in regards to the modern knee replacement and hip replacement. And technology and the techniques that we use have changed over these years. What we did 40 years ago is not the same as we do now. The implants that we use and the metallurgy, as well as the types of implants are much more advanced, specifically in regards to allowing patients not just to have pain improvement, but actually improved function. And that's where a lot of the improvements have been made in regards to the technology. The surgical experience has improved in regards to, previously patients would be admitted a day before the surgery and stay in the hospital for a week. That has changed dramatically over the last 20 years. And now we're doing surgeries on the same day. The way that patients come in is to patients to be more active early on, and that allows us to see faster recoveries and less pain. And so those have changed, but the technology continues to change, not just in regards to the implants that we use. One of the biggest technology changes that we've seen is the development of a robotic surgery. And this specifically looks at bringing in the advances of high technology using a robotic arm and CT guided or radiograph guided types of surgery. The most common one that you'll see today is called Makoplasty, but that is one type of robotic assisted surgery. As you can see on the picture onto the right, this is the advances that this is one of the robots that I use. And this gives us advantages in regards to hip replacements, in regards to knee replacements, as well as in regards to partial knee replacements. We've seen advances in partial knee replacements, and we'll talk a little bit about that. This is not the same partial knee replacement that we did 20 years ago. They've seen a big advances in regards to what patients can benefit from that, as well as the rapid recovery or the same-day surgery. The surgery of the ability to come in the same day, have your surgery and go home has made a dramatic increase in regards to satisfaction and decrease in complications that are associated with surgery, and then the advances in the pain control, and we'll talk a little bit about that. So robotics, as we talk about those, it's not just we go push the button and a robot comes in and does the surgery. These robots are allowing us and assisting the surgeons to still do the surgery, but with much more precision and much more consistency in regards to the guidance. Specifically what they do is they bring in a saw or a positioning of the leg so that the cut of the bone will be made with exact precision. And this precision can be made within a 1/2 millimeter or within a 1/2 degree. And that's the type of precision that we're talking about. We think as surgeons that we can be very good about putting an implant into a position, but when we bring robotics into that, that can make a big difference in regards to our positioning of that. And so when you're looking at longevity and you're looking at how long an implant can last, as well as restoring the most natural anatomic position of an implant, the robotics has been shown to be very, very reliable and very, very accurate in regards to that. There's also been some evidence to show that with these types of devices that we can decrease the amount of soft tissue damage that can be done because of the fact that we do not have to do as much dissection because of the fact that the robotics can bring in such accuracy in regards to that. Dislocation has also been reduced in regards to hip replacements, and then pain, which is probably one of the most biggest concerns that patients have, has been shown to be decreased with the use of robotics. The partial knee. So the partial knee replacement is not a new technology, but what we've found with the use of both robotics and the partial knee, it allows us to replace one portion of the knee. So some patients will have arthritis in one area of the knee. Sometimes it'll be throughout the entire knee. If it's a patient who has one portion of the knee that's affected, the partial knee replacement may be a good option for them. And if you've had one of these types of surgeries, the technology has even changed in the last 5 years in regards to what we can do in regards to restoring an anatomic or more natural feel to the knee. And the advantage of this is that we do not have to take some of the ligaments that we would have to do in a total knee replacement. It allows patients to have a more natural feel because those ligaments are maintained. And obviously they keep some of the normal anatomic features of the unreplaced portion. The longevity of these implants has improved dramatically and is no longer thought of as a knee replacement or a partial knee replacement will hold you over to a total knee replacement. But there are patients now that we see that they can have a partial knee replacement and that can last for decades or give them long-term relief, never requiring to have a total knee replacement. However, there are strict criteria in regards to who are candidates for these types of surgeries. And because of those, being evaluated by your orthopedic surgeon can give you a better idea if this is a good option for you. Same-day surgeries. So the advantage again to this is that you can go home the same day as the day you had your surgery. This is not a surgical option for all patients, but if the most common criteria that we use for these outpatient surgeries are patients who are less than 70, have support at home or a family member that can be with them during that time of the initial postoperative period, and have very limited in regards to medical comorbidities or conditions. And so these are options for patients. And the patients, I mean, the fact that you can go have surgery, go home, sleep in your own bed, eat out of your own kitchen, and not be around some of the issues that can come with an inpatient stay has been very advantageous to many patients. And so this is an option for many patients and maybe something that may be an option for you, but should have that conversation with your orthopedic surgeon. Pain. Pain has always been one of the limitations from surgery, but specifically for joint replacements, we have seen advances and allow us to be able to do patients to go home the same day in regards to these types of total knee and total hip replacements. One of the advantages of this is that it allows patients to be very functional. It helps reduce the amount of sedation that we see and lets patients be clear-minded in regards to those early postoperative recovery periods. We use a multimodal pain management. It's not just giving you one medication and then allowing that medication to treat your pain, but we use different mechanisms. And it's by using these different mechanisms that we allow the body to be functional, but again, be very, allow you to be very clear-minded in regards to that. Specifically, our nerve blocks, we use numbing medications, and that doesn't just numb, a deep numb, but also goes down to the source within the knee or within the hip to allow you to have decreased pain. It's specifically at the site where the surgery is being done. And this decreases your need for narcotic pain medications It allows you to be able to ambulate the same day, and that's standing up and walking on your new hip or new knee replacement the same day that you've had it. Allows the muscles to reactivate early, and we found that reactivation of the muscles early improves your recovery and decreases your overall pain. And again, less nausea and less of that sedation or sleepy feeling that patients will have after surgery. Medications, one of the common practices I use is I use anti-inflammatories on the day of the surgery, before the surgery, so that patients are already receiving that type of pain modality before the surgery even starts, and then that continues into that time period after the surgery. Ice has been around for a long time, but it's still very effective as a pain control method, as well as decreasing anti-inflammatories. And we start that immediately after surgery. I'll put that onto the patient while they're in that early recovery period within the first several hours. And then physical therapy. Getting physical therapy the same day of surgery has shown to be able to decrease the amount of pain patients have, decrease the amount of complications that they have, and patients have reported less pain when they have that early physical therapy. And that's what you'll see with both the same day surgeries, that therapy of the same day, but also for patients who do stay in the hospital, getting them up and mobilizing them can be very effective in regards to that. At this time, I'd like to ask the audience if they have any questions specifically about hip and knee replacements or the type of surgeries that I do. As you saw in the pictures, the robot is basically a base. It has a base, and then the robotic arm comes off of that. What the robot is probably weighs over 100 pounds in regards to that. So it is something that is mobile, that we move in and out of the operating room, but then it sits in a stationary position. But it's probably the size of one man, probably about that size. So there's a lot of different opinions on that. In my training, I would do bilateral knee replacements simultaneously. And so some surgeons don't feel that patients are candidates for that or are not familiar with the techniques in regards to doing same day bilateral knee replacements. But I've been doing bilateral knee replacements for 10 years, specifically with the Navy and now with Southeast. So it depends on your surgeon. And there are some advantages and disadvantages, and that's a conversation you need to have to say, are you a good candidate for that surgery? Some patients are, and some patients are not, and it really depends on some medical conditions, and obviously the disease of the condition of your knee or hip, and your surgeon's preference. So before the surgery, my preference is a medication called Celebrex. The advantage of that medication is it has the anti-inflammatory response. It is a little easier on the stomach, and because most patients are in an NPO status, it can be less irritating to the stomach, and that's why it can be very helpful. After the surgery, it really doesn't matter quite as much because patients will be eating, but I would use Celebrex or naproxen as my number 1 and number 2 medications. So many different discussions in regards to what success would look like. You can ask your doctor, you can ask your physical therapist, but specifically the number 1 success question is the patient satisfied with their knee replacement? And that question has been looked at for many, many years in regards to that. So some studies will say that the success rate can be up to 90%, or some people even down to 80% success rate in regards to patient satisfaction. So the always question I ask is, why did those patients not satisfied with their surgery? What was it that made them not satisfied in regards to that? And what can we do both before the surgery and during the surgery to minimize those type of patients? And specifically, it is preparing for the surgery and then being able to work through some of those recovery periods afterwards. And obviously, from the surgeon side, is putting in implants with precision to make it more anatomic, to allow it to be more natural feeling. So in regards to long drives afterwards, there are some options in regards to that. Some patients will stay within the local area, after that, or do a short drive afterwards in regards to make that drive shorter. But I think if you're going to be going home after a 3-hour drive, I always tell you to give the driver, whoever's driving you, lots of sweet tea, and that will make them have to stop every hour, and that will help you get out. But mobilizing and getting out and doing that is a big thing. So if you're doing a long drive, get out, take those stops, and then rest. And that way you have time to both move, because that's the key. Joint replacements are a high risk for blood clots. So are patients who are sitting in a vehicle for a long time or an airplane. And so by mobilizing or getting up and moving, that's been shown to be the most beneficial in avoiding complications or blood clots after a joint replacement. Yes, and sometimes that requires different types of implants or different type of technique in regards to that. But changing the amount of motion in the knee can be individualized and is assessed during the surgery to allow patients to have the best functional range of motion, but at the same time, allow them to both have stability within the knee itself. Swelling can vary from patient to patient. It can vary from surgery to surgery in regards to that, but it is not unexpected for some patients to have swelling even up to 6 weeks. Some patients will even have it longer, depending on both their blood flow as well as some of the other changes that go on in the knee or the hip. But it also varies on some patients in regards to pre-existing swelling. Sometimes patients who have a heart condition can have a difficult time with that. It can depend on how the recovery is in regards to that. Some patients can be gone within usually 3 hours after the surgery. Sometimes it can be up to 4 or 5 hours, depending on pain control. Depends on how those initial physical therapy goes in regards to that. But it's one of those things. It's not a rush to get someone out get out the door in regards to their recovery, but make sure that they're safe to go home and that that the family as well as the patient is comfortable in regards to those situations. One of the concerns about steroid injections, which is what cortisone is commonly, it was an old medication we used, but we use that term to refer to steroid injections, is that if you get high doses of steroids and in frequent dosages can cause changes to the structures around the knee. However, what we'll do is we use those medications and control the amount of dosages, but also at intervals where it reduces or minimizes that change that happens in regards to the soft tissues, whether it's the bone or some of the other tissues around the knee itself, specifically the cartilage itself. But it has been very beneficial when you have a steroid injection, that what it does is, even though it may cause that potential for that, what we see the advantages is that patients can be more mobile, they can be more active, and that in itself is an advantage to someone with arthritis because it decreases the amount of pain that they have and improves their function.